All right, welcome everyone, and thank you for joining us on this Saturday morning, relatively early. I hope you all have coffee. We do promise that after we are going to take a break. That's the most important thing to remember first, and then after the break, there will be treats. So if you can just make it to the break, we are going to reward you. So thank you. So today we're talking about creating ESMs that both address the needs assessment findings and state priorities, but also are responsive to them, measures that can actually have an impact. And this is, I don't know if any of you were at the partnership meeting. Our team was here and we sort of did something similar, but sort of not as deep. So today we're diving deep. There's a lot of material to cover, so we apologize that it's dense. But there's a whole bunch of us. We're going to be walking around a lot, and we're going to be helping you out. So thinking about evidence-based or informed strategy measures and how to integrate them into a needs assessment process, that these are two processes that should not be separate. They influence each other. Your current ESMs might help you with the needs assessment. You can look at it and say, are these working? Are they not? You can also then use needs assessment to then help identify new measures, new strategies that might be effective in really advancing your NPM topic areas. So today what we wanted to do is, we're going to talk a lot, but we're also going to have you work together as teams. Keeping with needs assessment, we are looking at, you might have seen some of the potential organizing frameworks. We're going to give you a lot of ideas of ways to do things, but these aren't the only ways. But what we're going to look at today is both the ESM development and also needs assessment through the lens of equity here in the middle. And we thought, what better way to do it than the case study that we're doing today. We're going to be talking about safe sleep, which is NPM 5. So this is a good way to get people excited and energized talking about both the measures, but also thinking about health equity. So with that, I want to introduce the team. I'm going to have them introduce themselves. First of all, I'm John Richards, and I lead the MCH Evidence Project. But I couldn't do it really without this amazing team, and we have fun together, and we do a whole lot of work. So I'll turn it over to Amy.
Good morning, everybody. I'm Amy Mullenix. I am housed at UNC Chapel Hill. And I'm excited to be part of the National Evidence Center team and spend time with you this morning.
Hi everyone, good morning. My name's Alexandra and I'm also with Amy, housed at UNC Chapel Hill, and I'm so excited to work with you guys this morning.
And I'm pulling up the rear from UNC Chapel Hill. We're at the Gilling School of Global Public Health, and so we work with John closely and Deborah on the Evidence Center. Oh, and my name's Dorothy Salenti. I don't think I said that.
I was like, should I introduce you now, Dorothy, because you introduced me? I'm Deborah Perry. I work at Georgetown University. I'm the Director of Research and Evaluation for the Evidence Center.
Excellent. So what we're going to do is, the first thing you're going to see, there's all kinds of goodies here, but the first thing is actually under your workbook, there's a little page that says before the conference, and I want you to take a look at this and reflect. You can circle the star that sort of indicates your level of knowledge about three areas. And the first is, what is your comfort level when we talk about evidence and using evidence-based strategies and digging into what really works for what populations? The second piece is what is your comfort level or your knowledge about an organizing structure? Today we're going to be talking about using a specific organizing structure called results-based accountability, or RBA, and this is going to guide our thinking as we develop these. So, do you know RBA? Have you used it? Have you used some other sort of structured approach, either in your needs assessment or in your development of ESMs in the past? And it could range. And the third is your knowledge of some of the MCH tools that are at your disposal. And hopefully we're going to talk a lot about those. So if you just sort of circle the stars that sort of indicate where you are with your knowledge here. And then the next step is we're going to this is the first time to interact, so we'd love for you to just introduce each other at your table. Since you're going to be working for the next 3 hours, you're going to be best friends by the time this is over. So we're going to take just a few minutes. If you could just sort of say who you are, what state you're from, And you can share your little stars with people so everybody feels we're at the same level. So 2 minutes to do this. All right. So hopefully we're making some lifelong friends here. If not, hopefully, at least for the afternoon or the morning. So we have a busy agenda today, which I have up here. It's also on, I want to point everyone's attention to this really cool workbook. And Alexandra came up with this idea that since we're doing all this work together, we're taking us back to elementary school. Everything is in this book. So at the end of the day, you can take this, and we're going to be referring to it. It has key information about the work that we're talking about, but then it's based on experiential learning. So there's a section on learning, and then on every page there's a section on doing. And we're going to be going back and forth with these two topics pretty much the whole day. So today we're going to start with talking about what the resources are. Then we're going to dive into the differences between population and performance accountability. And Amy is really going to guide us through a journey with this. And then Alexandra is going to really jumpstart us into an activity which is called Turning the Curve. And this is really how to look at the data that you have, how to project a course to improve that data, and then really working backwards from what your outcome is to what are the strategies that you need to create. So we are going to take a break a little before 11 o'clock. We're going to come back, wrap everything up. You're going to have this awesome workbook to take back and make all your friends back home jealous. And then we're going to come up with some strategies for what's next. So with that, I'm going to turn it over to Deb, who will sort of ground us in what is the Evidence Center.
Good morning, everybody. Thanks again for joining us this morning. As John said, we have a lot of content, but we wanted to just kind of make sure that we were all starting from the same foundation. And this team is so pleased to be doing this work with you all in the field. The MCH Evidence Center has only been around for just a little over a year at this point at Georgetown in this new iteration. And so we have a lot of exciting new tools that the team is going to dive deeply into over the next few slides. But we wanted to just kind of say where we're coming from in terms of this work. And certainly, as the title of our center would suggest, evidence is a foundational pillar of what we're doing. And I think we all have over the last few years, really understood how important it is that we ground what we're doing in evidence, but we take, a very specific view of evidence. Certainly, evidence is what comes out of rigorous scientific work that happens in universities through randomized control trials. And I think those of you who are involved in the home visiting work know that we have in that part of the field evidence-based models that have gone through a certain level of rigor and have certain kinds of outcomes that we can reliably expect to happen if we implement things with fidelity. That's really important, but I think we also have to be very honest about the fact that we don't have that level of evidence across all of the domains and areas in which we are asked to do work in MCH. And so we have also, in this Evidence Center, really tried to make sure that you have access to a variety of things that are evidence-informed, including things such as things that have gone into Innovation Station that AMCHP maintains, so things from the field. Sometimes we call this practice-based evidence. So we really are taking a relatively broad view of where the evidence is, and I think it's also important to point out that even when we do these randomized control trials and we have these very strong effects, we don't always have those same effects for different subgroups and populations. And so as we're doing this work, we just want you to understand we do have this broader lens. We also are seeing everything through a Title V focus. So we really learn from and understand the work that you're doing in the field. We understand that it has to be practical as much as some of us sit in universities. We also actually do a lot of work in the field. And so we really want to make sure that it's in alignment with your expectations and work. And then finally, we really need to make sure, as we're going to spend a lot of time today, that we are both thinking about the population focus, which is our duty as MCHers, as well as performance-based implementation science. And I think I got given this slide because I'm maybe one of the only people who knows that this phrase zone of proximal development comes from Vygotsky, which is a very famous Russian theorist in early childhood psychology. And the idea here is that we want to provide scaffolding, as parents do for young children as they're developing new sets of skills. We want to provide scaffolding so that everybody, no matter where you're starting from, can move along the continuum of gaining skills and knowledge in this area. So hopefully you have that experience this morning, and that we're meeting you where you are and helping you kind of build your skills into the future.
You might notice that the stars that I had you fill out kind of align with our 3 areas that we're talking about. We're very tricky this way. So we don't just sit at universities, we actually do real work. And some of you have actually interacted with us in the past, and I'm going to have Dorothy come up and talk about the types of TA that we offer as a center, because we are here to talk to you and tease out all of these ideas.
Morning, everyone. How many of you have had any interaction with the Evidence Center to date? Okay, so certainly feel free to chime in if you have some examples. I think our secret sauce at the Evidence Center is that we have been in the field. We've worked in local health departments, we've worked in state health departments, we worked in MCH programs. And so sometimes, when you're offered assistance or consultation, there may not be a sense that the person really understands, the world you live in and your context, but we really do get it. And some of us are more new to this technical assistance and consultation activity, and others have been doing it a really long time, but we try to keep ourselves up to date by connecting with you. And so this is really as a partnership. But some of the things that we offer include doing advanced searches. So if you're challenged by, well, what do I do about this problem or this solution? What is the solution to this problem? We can take the time to look at what's been published, either in peer-reviewed literature or white papers or other resources, because we know that your time is really stretched, and so to have us as that resource is helpful. We're also very familiar in results-based accountability as a technique and a framework. There's lots of ways to get to results. There's lots of different frameworks. I just heard one on the TV this morning. Some guy just published How to Be a Millionaire, and there's like 700,000 new millionaires a year. I'm thinking, well, that's a great result. Like, how do we do that? But so there's lots of ways that people have thought about having the greatest impact and achieving your goals and your results. But we're going to talk specifically about the results-based accountability framework as a tool that's worked really well in government settings. So government's different than private sector, and so we have to adapt our approaches given our context. We participated in a lot of the block grant reviews last summer. We're going to do that again this summer so that we can stay in touch with your issues and your challenges. And so we were helpful, I think, in thinking about what you're proposing as your ESMs, and are they measurable, and are they the right ESMs for the results that you're trying to achieve? So we provide, I think you saw the reports for your states on the ESMs that you're proposing and you're continuing to work on. So we help you adapt those and develop new ones as needed. And then our process is basically that we provide you with some standardized information through these reports and reviews, but then if you want to work with us more closely or more long-term, we'll have an exploratory call with you, and Alexandra on our team is really the point person to set up these calls, and we'll just listen to you basically and hear where you're at and what you're hoping to accomplish. And then we can provide ongoing follow-up, including coming to your state and meeting with your teams or doing it virtually by phone. As John said, we're customizing our support based on where you are along your continuum, and so it's very individualized, which I think is really important. It's not a one-size-fits-all approach. So hopefully after this session, you'll think about ways that we can engage with you, and we'd be happy to talk with you more throughout the conference if you're interested. Thanks.
And what Dorothy was very humble about is the fact that her team runs the National MCH Workforce Development Center. So a lot of times TA is a holistic approach. So you might start with evidence, but you might turn out that you end up in a cohort of theirs. So it's a really nice way to receive holistic TA. So, but in addition to TA, because sometimes we know that you're busy and you want to do some of this work yourselves, and we both offer to help you fish, but we also teach you how to fish. And there are a lot of tools out here. And we're really happy. We launched the MCH evidence site and the corresponding MCH Digital Library. They've been sort of reinvigorated. And there are a wealth of tools on both of these sites. And we're just going to go through real quickly to give you a sense that you actually have the power. Anytime a topic comes up, NPM related or even outside of that, a good first place to start is on one of these two websites. So if you go to mchevidence.org, you can see here we sort of have 5 goals of the project. And we provide tools for you, we provide TA, we provide additional learning resources. We have an expert team of both people in the field and people from the research community to help answer questions. And then we have the more expansive digital library. So I'm going to take us just on a really quick tour, and Deb and I are going to sort of go back and forth here. But I will say, the first place, and I'm really excited about what we're calling the NPM portal pages. And there's a ton of information out there, but we are, by NPM topic area, we are aggregating all of the evidence, all of the promising practices, everything together into one place. So in this case, you can see our portal page for NPM 5, which is Safe Sleep. We have some introductory resources. Then we have a summary of what the evidence says. In addition to that, because we know sometimes you look at the evidence, you say, oh, it really doesn't speak to me in my state. We have promising practices from the field. A lot of these we draw from Innovation Station with our partnership with AMCHP, but we also have links to the What Works for Health, anywhere that we find practices that are working. What I always say, at the next part, we have sample ESMs, because when you're developing ESMs, sometimes you think, oh, does this work? I don't know exactly. We don't develop measures every day. We have some guideposts for you. So this is a good place to start with. In addition to that, there are links to other state ESMs, and Deb will talk about that in a second. And then the other thing is we really try to partner with our other MCHB-funded TA centers. So for most of the NPM topic areas, there are resource centers that are funded just to do that topic area. So what we do is we provide the best of their resources at a one-stop shop. So this is a really great place to sort of dive into. From that, here you can kind of see, here you can see that you can link in, you can get the promising practices, you can get example ESMs. So it's all right there. And the good news is we're making these better all the time. Pretty much every quarter, we're going through and updating each one of these NPM topic areas. Again, additional learning, there's a lot of, if you really need staff development for this, through the MCH Navigator, we provide that additional learning. All right, and we have a lot of databases. All right, so Deb says go on. I'm just going to talk. So we love data here, and the best way to capture this information so it's easily accessible to you is with our databases. So on the MCH library site, you can actually tap into all of the peer-reviewed journals that are there, and it's a good place to start if you want to see what is out there, what has proven effective once you've been on our topic page. But we also have what's emerging. So if you click on the bottom here, you can actually see, you can get live updates of what's coming out through the National Library of Medicine. And this is good too if you really want sort of the cutting edge pieces. Here we have this state ESM database that I was talking about, and this is so important if you are working on a topic area like safe sleep that you just don't have experience with. It does not hurt to see what your neighbors are doing. What are other states in your region doing? What are jurisdictions across the country doing in this topic area? And you can search, right now you can search by NPM area, by state, by region. We are also soon going to have the ability to search by methodology, so what your strategy is. If it's in partnership gathering, you can see what ESMs out there deal with partnership gathering. If, for example, you're doing breastfeeding and you want to see who are using lactation consultants, you can search for that too, just to get a sense of what are the other states doing and how can I possibly leverage what they're doing to increase the work that you're working on in your state. And then finally, some of you might have seen these, we call these our ESM Reviews. And what this is, this was our first analysis of all the ESMs across the country to see where we are as a field. And it was a conversation starter. We were looking at it, we understand that everybody's in a different place, but we looked at all the ESMs and we sort of put them across a matrix, this results-based accountability matrix, to see how we're measuring them as a field. So you see there's what we call the blue cover, which is sort of the national summary, and it gives examples of, for each NPM, what are some ESMs that you can use? What is the evidence? What are promising practices? But then we took what you see on the right-hand side here, the red covers. Here, every state, Title V and SHIN director were sent copies of this, and you might have seen them in your state or jurisdiction. You might not, but you can always request them. We're happy to send this out. And what we did is we looked specifically at the strategies that you are doing locally to see, how do they sort of match up both across the state and across the country. So these are two really good places to start. We'll be doing a second version of this report for the next block grants. And again, this is just a way to get you thinking about evidence and the process of how to make these ESMs a little stronger. We also have a number of learning resources, I said, through the MCH Navigator. So this is the place to go for very specific, NPM-specific learning resources. And then our team of experts, which we call upon. If you give us a call for TA and we don't know the answer, we have people that we can talk to about what strategies might work for which populations. And then finally is our MCH Digital Library, and this, I will say, has turned out to be, we've been operating the library for many years at Georgetown, and we keep adding to it. Right now there are about 50,000 items in this collection. So pretty much even if it's outside of your NPM work, if it's outside of needs assessment, you can go here and you can find topics. And what we really do is we have these Title V toolkits for specific needs like evaluation, for infant mortality, very specific topics that you can go and get information. But also we have a Google-like search, so you can just type whatever you're looking in right there and get a ton of information. I will say about 85% of the material is available free, full text online, so that's always great too, so you don't have to go and find the material once you identify it. All right. I'm going to hand this over. Since we're sort of merging RBA and needs assessment, this is kind of important.
All right. Good morning again, everyone. This is sort of a transition place between talking about our evidence center, and then I'm going to transition us into needs assessment and results-based accountability. So I want to pause. John just shared a lot of information about evidence resources that are available. Does anybody have any questions about that? Or comments that they want to make? You ready to dive in to the next piece? All right, great. How many of you have heard of MCHneeds.net? A few people. Okay, great. This screenshot here is of MCHneeds.net. That is a collaboration between the Evidence Center, AMCHP, and the National MCH Workforce Development Center to sort of put together a lot of different tools that can be useful for needs assessment. So I'm looking at the image on the right. If you go to mchneeds.net in the Ready resources, this will be super helpful For those folks on your team who are new to needs assessment, for whom this is the first time for them through the cycle, it gives an overview of all the steps in the needs assessment process. It's really well lined up with the block grant guidance itself around needs assessment. There's a great video, a brief video that sort of gives you the big picture. So that's in the Ready button. The Set and Go buttons are really a deep dive into tools that you can use, examples from other states of processes, sort of systems mapping tools, for example, all sorts of different tools that different states have used for needs assessment. Some of them have case studies with them that describe how they've been used. So this is something to share with the folks who are working on your needs assessment if that may be of interest to them. So that's what our Evidence Center has contributed to, sort of generally speaking. Today we're going to really transition and talk about a particular framework that can be used for needs assessment. And like John and Deb both mentioned, there are lots of frameworks out there for needs assessment. Most states already have sort of a framework that you're using around needs assessment. I want to preface my talking about results-based accountability by saying it can be used in conjunction with whatever you are already using. You can pull pieces out of it that seem useful to you. I think for most of you, walking today through this RBA process will feel like, oh yeah, we do part of this in our needs assessment. Hopefully it will feel to you reinforcing that this is the way you are already potentially doing your needs assessment. It may give you some different words or a couple of pointers, but I think for most states, you do approach your needs assessment with the results in mind. The goal of doing a needs assessment isn't just to gather data, it's to define needs and then describe interventions, right? That's the long-term goal. And one thing results-based accountability is really good at is not letting us lose our North Star of the results that we're going for. So you can see the quote here. I think what I wanted to say was, in results-based accountability, it's based on a series of books by Mark Friedman. We have a few copies up here. I don't know, we might give them away by the end of the day.
Oh yes, we're not taking these home with us.
It's based on this book called Trying Hard is Not Good Enough. And he speaks very frankly to this idea that trying hard is great, and if it doesn't get you to the result that you wanted in the first place, then it's probably not good enough. So there's a lot of really good plain language in the book that sort of helps keep us from getting like spinning around in the weeds and getting the exact right wording in the ESM. It kind of pulls us out of that to have us ask ourselves, how's the NPM lined up with the NOM, and how is that coming down to our work and the ESMs that we're writing? So that's what it's based on. What else did I want to say? Yeah, it's a really good sort of, like I said, North Star. You identify needs in your needs assessment. You then connect them to results that you want to see. Most often, those are the national performance measures. Those are our results as Title V that we're responsible for. You are then connecting those results to specific activities in your action plan that you believe are going to get the result that you want, that will address the need that you identified. And at the very bottom of that cycle are measures. So we're going to spend a fair amount of time today talking about evidence-based and evidence-informed strategy measures, the ESMs. Those are sort of at the bottom of that list. So to describe that further, I want to just sort of give an overview, and then I'm going to draw it live. I feel like sometimes it's useful to have a visual, so you'll get to see my terrible drawing of a road and some sad little trees on the side. You can maybe put that there. So overall results-based accountability lives in these sort of two domains. One is population accountability. That's on the top. And performance accountability sort of lives on the bottom. This is an intentional way for us to understand that our work in Title V we are not entirely responsible for the national outcome measures. And I want to say that again because I feel like we feel like, you know, the national outcome measures, we support those by choosing national performance measures, and somehow we feel like the activities and programs that we do should somehow, on their own, change, or that we're somehow responsible for moving the national outcome measures on our own as Title V. Results-based accountability is a very clear way for us to understand that while we are partially responsible for those faraway measures, we are not entirely responsible for those measures. So I'm going to try to describe this here. Let's see. Oh, I'll use this microphone. So our case example today is going to be safe sleep. Our case example is safe sleep. And I would like to hear from you if you can share with me, so the national performance measure for safe sleep is sleep-related sudden unexplained infant deaths per 100,000 live births. So for those of us who work on safe sleep, for those of you, is anybody here responsible for your safe sleep activities in your state? Or contribute to those? So there are several people. Good. You are going to be our experts today. Lucky you. So children who live to their first birthday, that's sort of equivalent to our national outcome measure, right? That is our national outcome measure. It's the sudden unexplained infant death mortality rate. Another way of saying the sudden unexplained infant mortality rate is the number of children who live to their first birthday. In results-based accountability, you would use this in a community. It's a community process. You can go into a community, walk through a turn the curve activity, which we'll walk through today, in about 2 hours. You would not say to them, our goal is to reduce sudden unexplained infant death, right, in a local community. You would say, we want more kids to live to their first birthday, and we want you to help us figure out how we can do that. So those are what we call in results-based accountability, those are the above the line, that's the above the line language. So there's a line here, this is population. This is hello? This is performance. That means that you as Title V work down here on the road. These are things that you can touch with your activities. The population outcomes are here, farther away from you. They're hard to see. On that picture there, you can't even see the end of the road. You cannot see children living to their first birthday. You know that you own a piece of that, but you are not entirely responsible for that. So my question for you is, who else cares about kids living to their first birthday other than people in Title V? Parents? Who else does activities around this? Providers, daycares, schools, hospitals. Anybody else? There's all sorts of partners. So for me, I'm just a visual person. There are other people who are also wanting to be on this road to help kids live to their first birthday. Hospitals they have their own little path, right? They're doing education, back to sleep, safe sleep education. Parents are also on this road. They're making decisions about how they put their kids to sleep. Daycares are making decisions about their policies in their daycare, how they might educate parents about safe sleep. There are all sorts of people in the community. So above the line, we are all contributing. That in results-based accountability is what we call population-level accountability. And the measures for population-level accountability look like what we think of as national performance measures. So this is national performance measure number 5, safe sleep overall. That means that if it's above the line, I'm just going to write up here, NPM. Title V has an important role to play in moving the needle on all the national performance measures, and Title V is not solely responsible for moving that needle. What we are responsible for is everything below the line. In results-based accountability, this is called performance accountability. I just want to say, because RBA uses the word performance, we use the word performance measures up here to represent population. Results-based accountability is using performance because they're talking about your performance as Title V. If it's below the line, these are Title V activities. These are the things that you are writing your ESMs about. This is what is in your action plan. These are things that you can control. So that's the general picture of what I want to leave you with. We're going to work through this very specifically, but we see this a lot in our evidence reviews and in block grant reviews. I think one thing we want to leave you with is make sure when you're working on your action plan that you can draw a clear line in your own mind between the NPM with the understanding that you are one contributor to changing an outcome that's above the line. Everything below the line, you need to own. These are your activities, your money, your staff, your contractors below the line. What you need to be measuring here are the things that you are doing or that you are funding. Your ESMs should represent your own work or the work that you fund. And we're going to get way more deep. I'm probably way over my time now. So we're going to get more into that in a little bit. I have 15 minutes? Awesome. Okay, so I'm going to take questions on that. Is that clear? Helpful? I should also say that the Bureau did not use the RBA structure when they designed their the whole NOM, NPM, state outcome measure, state performance measure, and ESM process. So it's not a perfect fit. But there's also no right answer, right? When you write your ESMs, no one is grading you on perfection. You are getting feedback on improving those ESMs. But RBA and the block grant process or structure line up really well. But when you get to the line here, it gets a little fuzzy. But I would say, generally speaking, it's a good representation of where we want to be. So I'm not going to talk about, I'm going to start on the right side of the slide because this is what I was just talking about. So this is sort of a summary of the population versus performance accountability that I talked about. So for the population, you are thinking about the results you and all of your partners in your state want to see. You want fewer kids to die before their first birthday of SUID, essentially. The indicators that you use to describe that are your NPMs and your NOMs. Those are essentially given to you if you select this measure. So in Title V, we spend, I feel like, less time thinking about what's above the line, essentially, and our energy is spent sort of on below the line. The performance accountability are your strategies, which are the ones that show up on your action plan, the programs that you do, and what you use to measure them. Those are your ESMs. This public square RBA indicator criteria at the bottom essentially just says when you use RBA for those population measures at the top, you want things that when you talk to your partners in the public square, people who are not in public health, that folks will understand. So it's that example, fewer kids die before their first birthday. It's understandable to everyone in the community. If you want to go do a turn the curve RBA process with community members as part of your needs assessment process, that's the language you're going to use. You're not going to have them give you input onto your ESMs. That's internal to you. That's you being accountable for your own work to yourself on your path to influencing the outcomes. But I do want to just share the 7 population accountability questions in RBA, in my mind, are a great double check for our needs assessment process. These are essentially the questions, right, that you ask as part of the needs assessment. What are the quality of life conditions that we want in this community? That is the fundamental needs assessment question. What would it look like if we saw this? How can we measure those things? And how are we doing? So this is when you bring your data, your last 5-year data, you show the trend for safe sleep in the community. You show them in the community that this is how we're doing, and we want your input on what we're doing well, what we could do better. What are the factors that we can potentially address with our Title V funds and staff? Who else has a role in helping us do better? And what do you think works? And then finally, the last question is, what do we propose to do? That just really lines up then again with your action plan. If you were starting in a vacuum and you didn't have 15 NPMs to choose from, this is where I would suggest that you start a needs assessment process in local communities, walking through this activity. It helps you walk away with a really clear picture from the community of what they want you to do and what they want you to measure. I feel like in Title V, we kind of have our buckets already established, and so this, in many cases when folks have used this for Title V, they modify it using the domains, for example, perinatal health, women's health, to sort of help folks find parameters around what you're going to select. We're going to spend most of our time today on the below-the-line activities, the performance measures, the things that you are responsible for, but I did want to sort of give this general overview for RBA. All right, what do we have next? Is this you? No, it's still me. Okay, still me. Dorothy said go back and explain public square. So yeah, so this is for the population health level. This is a measure or an indicator of health in the community that you could walk into the public square and say out loud, and people would understand your language.
So like a physical public square.
A physical public square. This is like in Boston Commons, you could walk and say, we want less poverty. That's a population level indicator. We want fewer kids to die. We want more kids to live until their first birthday. Those are public square indicators that seem pretty intuitive, and I think because we're always down in the weeds, we sometimes forget to link our work all the way back up to those national outcome measures. I mean, that's what we want. We want fewer kids growing up in poverty. We want fewer kids dying before their first birthday, all sorts of those things. If you're interested in this part of RBA, the book is really good in helping connect us back to our roots. I mean, that's why we all got into this field in the first place. We want fewer kids to die before their first birthday, right? Or fewer kids to grow up in poverty. So it is the indicators that you use, especially useful in the community where we describe in lay language what we want to see happen. All right. Performance accountability questions. So like I said, this is kind of more in the area of where we live most of our Title V lives. This is below the line. These are the Title V activities. And these are the questions we ask ourselves. Who are your customers? So think about safe sleep. If you are using part of your Title V block grant money to try to have an impact on safe sleep in your state, who is your customer? This is where, that's a hard question. This is one place where RBA, I think, can challenge us to think a little bit differently about our work. It uses the language of customer intentionally. The first thing that comes to mind for me here is, in a lot of Title V programs, we spend time and effort doing education for hospitals on safe sleep practices. In that case, your customer is a hospital. You are serving them by providing evidence-based training, coaching, support, follow-up, educational materials. They are your customer. Can you measure whether or not that hospital is better off for the fact that you as Title V showed up and partnered with them? That's the question that RBA would have you ask. How can you measure that? How do you know that they're doing what you asked them to do when you leave? You could write an ESM about that and try to measure that. How are we doing on the most important ways that we're trying to serve our customers? You could see this could be similar for daycare staff training. I mean, we in Title V do a lot of training and technical assistance for other people. In that case, our customer is not the mom who makes a decision to put her baby on her back or not. It's a proxy. It's the daycare staff, it's the hospital staff. It could be the public education campaign. How are we measuring the penetration of our public health education campaigns? So these are the questions that we ask. Who are the partners that have a role to play in doing better? I feel like Title V is like the best public health agency in the world in terms of finding partners, leveraging partners. We pretty much rock out number 5 in my experience. And then we ask ourselves, what works to do better? This is where you link yourself back to the evidence. And I think John is going to share a little bit about the evidence. The emerging evidence, spoiler alert, is that hospital education doesn't necessarily work all that well. Am I right? Yeah, that actually, there's not a lot of evidence that providing training to hospital staff works really well. So again, RBA is just through the simple list of questions, forcing you to ask yourself, right? So this is a staff activity. You're asking your own self this question: what works to do better? Are there no-cost or low-cost options out there? For us, it's one thing that Title V is also great at, leveraging low-cost, no-cost ideas in partnership with other stakeholders or partners. And then what do we propose to do? So that's sort of the general gist of RBA. You ask yourself the 7 population questions, then you go below the line, figure out what you're responsible for, your programs, where's your money going, and you ask yourself these 7 questions. The strategies that you come up with that are going to go on your action plan, a good crosswalk for them is this silver RBA strategy criteria on the right. So are your action items on your block grant action plan specific enough to be implemented? Can they actually be done? How much leverage do you get from those activities? How close do you think the connection is between that activity and the NPM? Sometimes the connection is pretty direct and you can see the impact of your activity pretty directly. Others are more distal, and you need to think about sort of what really can you expect in terms of leverage and getting to some sort of movement on that NPM from your part of that work. We're going to talk about turning the curve. Will it turn the curve? That just really means, will it change the trajectory of where the data are going at their current rate? Is the strategy that you're selecting as part of your block grant action plan likely to be adopted by the communities that you want it to be adopted in? Title V is good at this too, I feel like, because you've done a robust needs assessment, you really heard your community, you are more likely to select strategies that are going to have uptake with those folks that you want them to have uptake with. And then your reach. Think about whether it's feasible and affordable. Can this actually be done? And then the ESM piece is then how you're going to measure that. All right. I said we were going to talk a little more about turning the curve. This is what we're going to spend most of the rest of the morning doing. Is you all are going to do a turn the curve activity. A turn the curve activity is what you do actively in a community when you bring this process to the community. So we're going to do that with you today. The basics of turning the curve are: where are we starting? So that's easy for you in Title V. You have epidemiologists, you have data for all of your NPMs. Your starting point is the data that you have. And the current trajectory is the second question. So you don't just want to say, our sudden unexplained infant death rate in 2017 was this. We're going to do X intervention and we expect the Y result. You have to think about what is the current trajectory of the data. So what you have usually you should have the last 5 years of data. So you're going to kind of just draw yourself, or have your epidemiologists more precisely draw you essentially a line graph that plots the 5 years or 10 years if you have it of data for the very thing that you want to impact. And then the dotted line represents what would happen if we kept doing, what would we expect to happen if we kept doing the exact same activities that we have been doing. So let's say that this line up here, because we want sudden infant death rate to go down, and this curve goes up. So let's say this is for breastfeeding. 5 years, you're on the trajectory from left to right. That breastfeeding rates are inching up, inching up. The forecast without action is the dotted line at the bottom. This is what would happen if your interventions looked exactly the same as they have looked for the last 5 years. If you decide to do some new intervention, or you have 5 partners and you're all doing a new intervention, and you feel like that's going to have an even bigger impact, the dotted line is what you project will happen to the breastfeeding rate with your new intervention. Your target is that high up line, way up there on the top. The comparison for you all is going to be the national data. So for some indicators in your state, you're going to be above the national line. For others, you're going to be below. This is just a really rudimentary way of visualizing your data, making sure that you're paying attention to what would you expect to happen if you didn't do anything different, and thinking, here's our intervention point, what is the difference that we expect to see? You all are going to get a little bit of practice on this in just a little bit. Oh, you're going to get practice right now. All right, before I give up the microphone, I know that was a pretty quick run through. That was essentially the whole book, except the turn the curve activity. So I want to just give you an opportunity to ask any clarifying questions.
And I will say the first person who asks a question gets copies of the book.
Get a copy of the book if you ask a question.
There we go. Except for Dorothy. You don't get a copy.
So my comment is that, Amy, can you go back to that other slide? In terms of thinking about public square and communication, so you would look at your data over time, and you would systematically predict what would happen if you did the same thing using techniques, statistical techniques, and you would also then project what might happen if you implement a new strategy. But then you would turn that into real people for your communication. So if you're thinking about, saving babies, how many babies are saved if you do nothing or you do the same thing versus if you use different strategies. So you always want to translate the information into layman appealing terms so that people can understand the impact, not the way we understand it in terms of rates, but the way they understand it in terms of actual people.
Okay, I saw this lovely lady's hand first. Sorry.
I think what I'm struggling with is, for all the strategies you might envision, is there a predictability rate that we can then use to apply to our population, sort of at risk, like in an epidemiology standpoint? If I use strategy X, I can expect a return on investment and improvement of 2 to 5%, and then I can apply that rate to my base population to make that prediction. Otherwise, I'm sort of feel like I'm groping in the dark making a prediction. Does that make sense?
It depends on how much you want to invest. It depends on your level of investment. So if you really want to statistically predict, you can use models to do that. And they're available? Well, they usually have to be developed for your particular situation.
Yeah, and frankly, I don't feel like I have that capacity, even though I have a very large department. I just don't have that. So if I could go on your website and get, 5 evidence-based strategies, can I have some level of outcome I might predict from using that strategy, some improvement measure, because otherwise I don't know what I'm measuring, I don't know how to make that estimate.
Well, and this is where we No, this actually, it's a really good question, because how do you predict that? We can see, if we go back to the evidence and we look at some of the studies that have been done, what you try to hopefully do, and if a study has been replicated enough, you can see, they had a 10% increase. So you go back to, and that's where our website is great, because you can actually link back to those direct studies themselves and start to predict. And depending on the methodology, if you're looking at let's right in my head right now, it's not on our safe sleep discussion, but lactation consultants. We have found that when you train lactation consultants for breastfeeding, that the rates do go up to like 3 to 5%. So that can help you. And of course, it really depends. You have to put in all the factors about, our population group. How does it work? Are we using the same model? In one case, it was a 24-hour lactation consultant line, and they tracked the number of hits that they had, the number of interventions, and then they saw an increase in it. So they sort of did a comparison that way. So it's not ideal, but it gives you a sense. I hope that answers.
Exactly what I was asking. All those kinds of data available, at least get you started.
Yeah, it'll get you started.
Yeah, I was thinking, there's good national data about what kind of benefit you get from raising taxes on cigarettes. Right. So I think for some things there are good measures, and others it's more, based on what we know from where things have been implemented in specific communities.
I guess I would add a little bit of caution. I guess that's my job. And say that to the extent that we have the kind of studies where we can get an effect size or a specific kind of measure of impact that you could reliably expect to see in a similar situation, I think this is where, we start having a lot of footnotes, right? So is your situation similar? Are you implementing this intervention with high fidelity? All of those things are things that would factor into whether we expect to see that same effect over time. We have to factor in attrition and all those things. That being said, in my very cautious way, I think it's an extremely useful piece of feedback for us at the Evidence Center as we're pushing out information about where we have good evidence to be able to give you guys exactly those kinds of pieces of information to then plot what is the expected rate of increase if we do, as John said, a similar kind of lactation thing, as long as you put a few footnotes at the bottom. And, for each of those things. So I think it's especially, even if you have a big staff, you may not have people who can sit down and help you with this kind of statistical modeling, right? So I really appreciate you asking the question. I think it's something that we can aspire for and give you cautiously pieces of information that can help you do that. I think the other piece that's tricky is what results-based accountability talks about, which is the cost of doing nothing. And that is another piece of this conversation that's really important, because we may not be able to, and we're going to spend a lot of time talking about this, the ability to turn the curve to actually change the trajectory of where we're at relies on a whole bunch of things, really understanding, for example, root causes, right, of very complex multifactorial things like why babies are dying. And if we knew all of that, we would be turning curves all day long, right? So I think just to the extent that this framework helps us think about this work in a more concrete way, where we're using our best available data, where we're honestly saying we have strategies that we know have given us this amount of impact, I think that's sort of what we're trying to do today.
And I think it's the argument for public policy. I find that when you go to try to make a case to spend money on anything, everyone says, well, what is the return you're going to get, and are you sure? And of course, we're never sure, right? But that's the argument you have to make, and and then a community says, well, are you sure? And what chance is it going to work? And you're like sitting there with studies that are remotely relevant,
Exactly.
and saying, I think it'll work, I think it's all tied together.
Exactly. No, I think that's really well said.
I just want to add one other caveat to the cost of doing nothing is thinking about the opportunity cost of doing the wrong thing. So if you're doing something, you're not doing something else. And I think that to the degree we can at least, implement strategies where there's at least some evidence of effectiveness as opposed to doing strategies where we're using our resources and we're not getting results. I think that's also an important consideration.
It's all about probability, right? We're trying to increase the probability that we're going to see the kinds of outcomes that we want, and one strategy for that is actually using things that have worked for other people with some degree of replicability, right?
Great, thanks. I'm sorry I didn't get more questions. We'll come back. To tie this together, I guess I'll just say, to summarize that, your 5-year needs assessment is an excellent opportunity to spend time, honestly, not just assessing needs, but thinking deeply about what you're going to do. I think sometimes we may not build enough time in our needs assessment process for this piece, which is examining potential strategies. So I think you're at a really great place in the cycle to pause and say, so these are the activities we've done. What did we really get for that? If we add up all the money that we've spent over the last 5 years, did we get what we wanted? Did we get what we expected? And are those activities the activities we want to carry forward? Are they supported by the evidence? So that's the circle I'm going to close. And then I'm going to turn it over to Alexandra. I think we're going to do a turn the curve right now for fun and practice.
Okay. Has anyone in the room participated or participated in a turn the curve activity? Show of hands or similar? All right, so this will be exciting for all of us to walk through this process today. So if you guys could go ahead and flip to page 5 in your workbook. So like we've mentioned earlier, the rest of this session today is really going to be working on this activity called turning the curve. And the way this process is going to be working, we've kind of been alluding to our case study that we're going to be working on up here. We're going to be talking about slave sleep. And as we're working through this activity, we're going to be thinking about safe sleep at the national level. All of you guys are seated at a table, and it has a population domain placed on your table. We're going to be asking you to think through a national performance measure as a group that relates to that population domain. And then as we're walking through this activity, we're going to ask you to think about that national performance measure, however it makes sense at your table. So we're going to be doing it at the national level. If there's a table that has a lot of folks from the same state or the same area or region, you guys could think about it at the state level, whatever makes most sense to you. But just know that when we're going through this activity, we're thinking about it at the national level. So there are 5 steps to turn the curve, and we're going to be walking through them, and you're going to get a chance to actually do each of these steps in your groups. The first step of turn the curve is how are we doing? So Amy talked a lot about this before in the previous slides, but this first step is really an opportunity for you guys to prioritize what you're going to be focusing on within your work. So for this first step, we're going to be asking you to identify the current trends of your data for that specific performance measure that you're working on. And we're going to be asking you to do that at a very high level pace. So is it increasing? Is it decreasing? Is it stagnant? And are we okay that it's increasing? Or are we okay that it's decreasing? Or are we okay that it's stagnant? So when you're doing this in real life, if you come across a performance measure that you're working on that you're okay with where the trajectory of the work's going, then that might be a lower priority activity that you want to be focusing on. So this is just a good way to kind of prioritize a QI check of, is this something that we want to expel resources and time and focus on? The next step of the process is thinking about what is the story behind the curve. So this is an important step in the process because before you start developing activities and action plans and really getting your boots on the ground with the work, you want to understand why and how did we get here. And before you develop activities around, you have to understand what that base is. When we get into this step, we're also going to be thinking about a specific type of measure that is really relevant in this area. So when we're thinking about the story behind the curve and how we got there, we're going to be thinking about barriers and competing factors, and we're going to be talking about a measure that's really relevant to these two areas of work. We're then going to move on and talk about the partners, and because this is Title V and resources are always something that's on the forefront of our mind, we're going to tie that in as well. As maybe mentioned before, when we think about national performance measures and national outcome measures, it's Title V doing a lot of the work, but then you also have other key players that are necessary to get this work done. So that's an important part of this step. Then we're going to move on to what works to turn the curve. So this is the fun part of the activity. This is where you get to brainstorm and be really generative and just come up with as many activities that you can think of, low cost, no cost, billion-dollar cost activities. And then Turn the Curve provides a systematic way to kind of prioritize what those activities are. And then finally, the fifth step in this process is what is our action plan to turn the curve? So for this part of this session, we're really going to be focusing on the measurement piece of your action plan. So once you develop those strategies, how are you going to measure that you're getting the right work done? And that's how we're going to kind of cap off this activity. So does anyone have any quick questions before we drop into the activity? All right, I'm going to turn it on to John to get us started.
All right, I'm here to provide a message from our funders. And actually, before I do that, let's just all take a second to breathe, because we have been talking a lot, and there's a ton of information, and there's going to be more. This is heavy stuff. It's really, you gotta get the synapses going, and it takes a few times to go through this process before you feel, oh, I got all the components. There are a lot of spinning wheels, but this is complicated stuff. So just breathe for a second, and I'm going to talk to you about evidence. We always start this whole process. We are the evidence center. Of course I have to say evidence. Start there. We talked about the peer-reviewed findings. We talked about promising practices, what other states are doing, what other local groups are doing. And of course, this is the plug. Always go back to our website to find this. Contact us. We are really happy to help you through what really works. So I'm going to give just sort of a really simple, and I apologize, it's really hard to read up here, but in your book you'll be able to see just a really quick summary of the evidence that we have. If our case study is safe sleep, I'm going to give you just a quick go-round, and you'll see where we need to grow immediately. So what we do know, and I'm going to grab this. Oh, there we go. Perfect. There are some trends that we know from the evidence. When this evidence report was done, I think about 13,000 peer-reviewed journals were looked at. They were winnowed studies that, or even less. What we're finding from the evidence is, and it's mixed. It's always difficult. We do know that interventions targeting caregivers by themselves are somewhat effective. We also know that if you implement the caregiver, the provider, and the hospital levels, either with or without quality improvement, those show to be a little more effective. If you put quality improvement in it bumps it up a little bit. We do know that our national campaigns have been very effective, and I'm looking at our representative from NICHD who will be happy to hear that. We also do know that there is a little less evidence on interventions that focus only on the healthcare provider. So it's really tough to get a sense what works out there. But there's emerging evidence too. I was contacted by the Bureau who said, we're happy you're talking about safe sleep. We're finding this is just sort of cutting edge, that several HRSA-funded initiatives, and I'm reading this right from them, and the Safe to Sleep campaign that provider training that integrate effective behavior change models. These seem to be very effective. New mobile health message interventions seem to be very effective. And Also, again, quality improvement initiatives by themselves and systems. You know, what does this mean? This means you have a lot of places to go to, and you can really dig into whatever programs you think might work. You can see, has this been tried before? What are the results? If this addresses a root cause, it might really help turn that curve. So don't forget to start here. That being said, let's look at the data real quickly. So in this case, you're going to see, and throughout the workbook, you're going to see our sweet little baby up here, just to reminding us that we are talking safe sleep for the example. You're going to be talking about whatever NPM is interesting to you here. But here, let's look at the data. So the first thing we do is, as both Amy and Alexandra have said, you know, let's plot that data out. Here at the bottom, you can see in red, this is the first good piece of news, that infant mortality here in red has been decreasing. Over the years, it's decreasing. It's plateauing out a little bit. We're not so happy about that. That's great. What is bad here is these are our SIDS and SUID deaths. And you can see that they started to go down, and this possibly is, you know, if you talk to your EPIs, they might say this could be the potential of a diagnostic shift in which we are not diagnosing SIDS as much as before. But you will see for the last decade or so, we've been very stagnant. So it looks very much like this. And that's the cost of doing nothing or changing nothing, that we're afraid that trajectory is going to go on that way. So understanding where we've been and where we might be, that's really the first step here. So this is real life data. So you can get a sense that this actually, you can boil it down to something very simple. Oh yes, and equity. And you know, when we get to equity here, we do know, thank you. This is actually a couple of slides ahead, but let's take a look at this equity here. Here we do have different SIDS death by race and ethnicity. So you can really see, and it's hard to see, but you can see in your workbook too, that the rates for African American women are much, much higher. Here we're almost more than double that of white women, white families. So here we know this is the perfect example of, wow, we need to focus on strategies that will address the causes of this health inequity. And there might be many reasons. You know, when we worked with Safe Sleep, we found that, you know, the messaging did not apply to everyone. A lot of people didn't see themselves in the messaging. A lot of one of the great researchers, and this was great case-based studies that came out locally in Washington, D.C., of families who said, you know, I hear the message and I know I should put my baby back to sleep, but I can't because I'm afraid of leaving my baby alone in the crib because there are rats in the apartment, or there are people that I don't know who might walk in and out of the apartment, or I just feel more safe with my baby next to me. Well, these don't apply to everyone across the spectrum, but those are the families that are most vulnerable and are most in need of these specialized interventions to really change that, you know, to break that, to get us to sort of some equitable solution here. I think that sort of covers it. We jumped ahead a little bit, but let's go back for a second. All right. So this is the first time where we're going to actually have you all, now that you've sort of heard what we're doing, we want you to take, you know, you're all sitting at your table now. As a group, think about a national performance measure, and they're up here if you want to take a look at them. Decide on one NPM that you're going to work on as a group, because over the course of the next hour, we're going to have you really just sit down, think about, you know, do we have data for this? Can I talk about it? Is this a need? And then, you know, as a group decide, and then we'll come back in just a few minutes and start the process. All right, and breathe. All right, everybody. We are going to sort of pull in. We actually have a question that came up that we're going to answer. But first, I am going to say, in addition to books, we have all kinds of fun things. This is my shameless plug. Come visit us at our exhibit, because we have the best stuff. We have awesome bags. We have awesome mouse pads that say, I am MCH strong, because we are. And we have the best thing of all. We have real people who will talk to you and answer these questions. So the question that came up, and it's a really good question here, was what do we do with the data, especially given that the national survey data may have changed, the baselines have changed for so many of these indicators. How do we address that? So we did a quick confer here, and does anybody want to take it, or should I? All right, thanks, Amy.
I'll start, and I don't want to offend any epidemiologists in the room. What I would say to that is important to recognize, and the point of looking at your data is to have the conversation, not to necessarily get the precise right answer. We know we don't have precisely matched evidence-based interventions that are gold standard. So for me, the point is to look at the data, sort of estimate the trend. If there's a gap because the data source changed or the question changed, that's fine. The point is for your team to have the conversation and say, overall, big picture, where's this going? That's sort of my...
Okay, I have two things to add to Amy's excellent answer. One is that measurement is one part of the story behind the curve, right? So that's just an important thing to talk about, and we should understand what error is built into all of our measures, because we have no perfect measures. So having that conversation, honestly, I think is a super important part. And then there's the concept of triangulation. Sometimes we have data from multiple sources that we can look at together that will help us sort of figure out what the trend is, right? So since we have no perfect measure of anything, if we have a couple of measures that are sort of getting at that same construct at either multiple levels or from different communities, can we start to sort of unpack what the trend likely is? So that's just my addendum.
And like John had mentioned before, our hope is that if this process really resonates you and you think you want to take it back and implement it in your agencies, you could go ahead and take home and replicate this process using your workbook. If you take a look on page 5, like Amy said, I mean, you're really thinking about, is this trend increasing, decreasing, or staying stagnant? So these little simple charts on page 5 is a nice reminder that you're trying to approximate, is this a priority, or is there something else that should really be in the forefront? So this is just a nice little reminder of that. Does anyone else do we want to move on? Okay. So we're going to move on to step 2. Which is the story behind the curve. So if you guys want to go ahead and flip to page 6 in your workbooks. Does everyone at their tables, have you guys chosen MPMs and thought about what the data might look like, whether it's increasing, decreasing, or staying stagnant? And if not, we're about to go into some more group work, so you can continue that then. But just know that going forward, you'll be thinking about that MPM that you chose. So like I mentioned, our case study is going to be focusing on safe sleep. And like I had mentioned before, the process of thinking about what is the story behind the curve is really when we get to that step of developing activities and then thinking through measures, really understand how did we get here. And that's where this comes up, this step in the process. So here we kind of broke up the story behind the curve into 2 key factors, competing factors and barriers. So you might have a really rich discussion, and again, this process can be very engaging if you're doing with your stakeholders. So the story behind the curve might be this long narrative, right, about how did we get here. But it also helps to take a step back and to really make buckets. For us, we thought that these 2 buckets might be helpful to think through, especially when we think about what are the activities that are we going to do to pivot how we're moving, and then also what are the really important things that we want to be measuring about our work in this area. So for us, we thought about 3 barriers to turning the curve in the past, again relating to safe sleep, and these are going to come up again, so I'm just going to go ahead and read through them. So one of them, lack of funding, right, to provide safe sleep sacks and cribs to participate in evidence-based strategies. We also found that we had disproportionate rates of SIDS and SUIDs stratified by race and ethnicity. And then we also found that trainings and outreach were geared only to parents while neglecting child providers such as grandparents, aunts, uncles, and child care providers. So this is what's going on currently that's preventing us to really turn the curve in this area. We also have some competing factors that are preventing us from turning the curve. So number one, funding. And then we also have some other things, such as competing factors related to breastfeeding initiatives, especially related to disproportionate rates among different race ethnicities. So we found in our make-believe agency that a lot of the staff that were working on Safe Sleep are also working on breastfeeding initiatives. Dorothy kind of alluded this before. If you start an initiative somewhere, is that taking away from somewhere else? And then we have a lot of internal staff turnover. So I want to go back to the second point of competing factors. So we're going to be talking a lot about national performance measures. We talked about national outcome measures. We're going to be talking about evidence-based strategy measures, so a lot of measures going on. And an important measure to think about when you're thinking about what is the story behind the curve is this measure called balance measures. Has anyone heard of those before? Okay, we got some hands in the back, great. So balance measures are really those measures that are developed to monitor and track unintended consequences. So Dorothy had mentioned this before. If you're doing something, is another area of your work going to be affected by that because you're taking away time, you're taking away resources? One of the very popular examples of safe sleep related to balance measures, as Amy mentioned before, a lot of Title V activities might relate around outreach and education. So if you have a best practice of providing education at well visits about safe sleep practices during those early infancy months and years, one of the balance measures might be the wait time that you might occur in the well visit. So if your doctors are taking time to explain best sleep practices, is that going to increase the wait times that you're seeing in the waiting rooms? Now this is important to measure because this might impede other parents and caregivers from taking their children to the doctors because the wait time is very long. So if you're not tracking this measure, and you're only looking at your national outcome measure, your national performance measures, and you're seeing that sudden infant death is not going down, then you don't know what's in between that's causing that. So that's why these balance measures are a great thing to think about. So we're going to give you a few minutes now to think about the story behind the curve. In your workbooks on page 6, we broke it down into barriers and competing factors, but also feel free to just generate some other backgrounds about why your national performance measure might be where it is right now. Any questions? So a few minutes to go ahead and do that.
So as we sort of pull back in, I do want to just bring up one thing. One of our partners reminded us, when we're talking about resources too, and actually our next step, we're going to be talking about partners. All right. So partnership is important, and when we talk resources here, this is one of the areas too where partners are resources. So especially in the case with breastfeeding, or safe sleep and breastfeeding, we shouldn't consider them as pulling resources away from each other. What we have found in a case where that you think that, wow, this is scary, we have a small pot of money, this can be your best partners. We did find in Safe Sleep that the safe sleeping and breastfeeding community ended up being the strongest partners for each other, where what one of the communities was doing, the other one said, hey, I can tap into that and bolster our message. So this is really kind of there is strength there, and something where you might say, oh, this is a pressure point. No, this could be your best strength. And because Title V is so much about pulling good partners together, let's spend a minute talking about partners in Safe Sleep. So when we were originally working with Safe Sleep, we said, oh, we know our partners. We know we have to get out there and talk to the families. We know we have to get out there and talk to hospital systems. We know we have to get out there and talk to the providers who are out there, and even childcare. We can get that. But then we start thinking, who are our non-traditional partners who we haven't pulled together. And then the light bulb starts going off, and you start writing down. Here again, we are brainstorming right now. We are putting it all out there, and some of these make sense, some internal partners, external partners, crazy partners that you never thought of. In this case, we knew we needed families, but then when we said, a lot of, especially when we're looking at health disparities, a lot of our families are going to WIC clinics. Let's partner with the WIC clinics. Let's talk about that. And that also pulls in our friends in the breastfeeding community. Church groups, again, really important when we're talking about health equity here. That the families who might need this message the most are the ones who are relying on their church for messaging. Let's make sure that they are engaged. Beauty salons, the same thing. Oh my gosh, where do women get their information? You're getting your hair done, you're pregnant. You're going to be talking about this. This is great. This is the perfect place to initiate safe sleep. Baby stores, grandmothers, because grandmothers we realize that a lot of grandmothers are saying, I put you to sleep on your stomach and you were fine. Got to talk to them. Grocery stores that sell diapers. Pharmacists. Oh my God, this one still amazed me when we found out that pharmacists wanted to talk to families about safe sleep. And there's a whole curriculum on it. It was like, wow, this was an off-the-wall partnership that actually has a lot of strength. And what is not on this slide, but if you go to your workbook, you can find on page 7, you can pull your partners apart a little bit and stratify them. Talking safe sleep, we found that there were these expanding levels of influence. You have first the families, the infant caregivers who are doing the daily dose. But outside those, there are all the influencers. And this might be the church groups, this might be the grandmothers. These are all the people who are talking to your families who are saying, hey, do safe sleep or don't do it. This was a great partnership. There were organizations within your state or jurisdiction that you might be able to tap who are doing this or doing something similar where they can link this. Then there are the experts out there. Our team of experts is great. We have our federal partners who are experts in this, who have national initiatives that we can tap into. And then we get into the broader realm, public policy, and then the general public. If you start small and you start thinking of who our traditional partners are, then who are our crazy partners? I actually just heard off the topic of safe sleep, because it's not all about safe sleep. Yesterday, I ran into the Title V director from New Jersey, and she was talking about this program that blew my mind, where they are now in WIC clinics, they're putting the arts into WIC clinics. So you go in for a WIC visit, and there's someone there who will paint with your children, who give music lessons, and this also helped to equity on a policy level, on a social level. She said this never would have happened unless she was at a meeting with someone from the Arts Commission, and they said our programs should work together. So this is a great place. When we get to the breakout, think creatively, brainstorm, and really come up with crazy ideas, because they really might work. All right. Okay, resources, and I'm going to hand this over to Amy, I think. Nope, I'll keep going. Okay, so partners and resources, as Alexandra said, this is what Title V does, and I want to say, look at the resources that you already have, but also look at the root causes. These are the sort of the two things that are really going to be able to push your initiative. So if you're saying we have a lot of crime on the street, I'm going to take it back a level to me. We have a lot of crime on the street. Well, why is there crime on the street? Well, there's crime on the street. There are no street lamps. Oh, that's a root cause. Well, guess what? We have a program that does street lamps. They're just not connected here. So we've identified, we have resources, we have a cause. If we come up with a strategy that addresses that root cause with those measures, there's probably a pretty good chance we're going to get that street lit up, and it's going to be a little safer for people to walk down. So that's a silly example, but it does show you sort of that it's really common sense. And again, we're brainstorming, we're coming up with multiple ideas. Think of all the possible resources you have. Think of what could be causing your data to either stay or drop or not go up fast enough. And then get in your head, start thinking about, okay, yeah, if it's dark and scary on these streets, how can we fix that? The first cause, you might say cause the lights. It could be that there's no police presence. It could be that there are no crosswalks, that there could be, then you think about resources. There could be local neighborhood associations that can come out. You could increase the police presence. So, we're just sort of teasing out, like, big picture, without specifics at this point, what are the resources, causes, and partners. So we're going to take I think we're taking a break. Nope, no break. Okay, we're just one more step. Sorry, I just want to keep jumping in. But this time I am handing it over to Alexandra.
All right, guys, so we're moving right along, and we are on step 4. And like John said, I think it's going to be a fun step for you guys. It's where you get to generate off-the-wall proposed activities to turn the curve. So you notice here that we have them separated. We have proposed process-level activities and then proposed system-level activities. So like we've been talking about a lot during this session, a lot of the work that Title V does is in that realm of education and outreach and technical assistance. And so these proposed process-level strategies might resonate really true. The system-level activities are where you're really bringing in the partners that you're working with. So you see hospital systems, you see the state medical exam. This is going in and out, I'm sorry. So when we dive into developing the measures for these activities, it'll be really important to think about what were our process level and what were our systems level activities, because you'll see certain trends, right, about where these activities fall within the type of measures that you're developing. So when you're doing this process in real life, again, you don't have to stop at 6. You want to be as generative as possible, but then you want to go back and think about what are those competing factors and those barriers that you discussed in the last step, and how is that going to influence what these activities really are going to look like. And you could really use that last step of what's going on right now, what are those barriers, to help prioritize what are the activities that are really going to make sense and really going to help to turn the curve and what are feasible. So when you are going through this step now, I'm going to stop talking in a couple of seconds. I want you to really think about all the steps that you've done so far. What are the partners that are available, the resources, what's going on right now, and how is that going to help us prioritize some of these activities? The first few times that you walk through this, the distinction between process level and system level might not be as clear. And that's totally fine. Just when you're thinking about process level, think about what's really in our wheelhouse. And for the systems level, who are we really going to have to bring in and partner with to really push that activity forward? And again, we'll be circling and happy to talk through what that might look like as well. So a few minutes to go ahead and come up with some activities, and then we're going to keep moving forward. Any questions? Oh, thank you. And this is on page 8 of your workbook.
What I love about this room is that everybody really is so intensely focused on their conversations at the table that even though I said I'm about to release you for a break, nobody wants to stop talking.
All right, so we're at the 5th and final stage of our Turn the Curve activity. So thus far, you guys have chosen an NPM that you guys were focusing on at your tables. You've kind of thought through what the current trend of data looked like for that national performance measure, so whether it was increasing, decreasing, or kind of staying the same. We talked through the process of looking at the partners and resources that are involved in this national performance measure. Then you guys kind of generated some activities to work to turn the curve. So I think some tables got off on conversations about current activities that they're doing in their work in their home agencies, and that's totally fine. And then some other tables also kind of generated some new activities related to the work that they're doing for this Turn the Curve activity. So the next part of this stage is action planning, and like I said, we're going to be focusing on the measurement piece of that. So whether you were thinking through activities you're doing in your day-to-day life or the new activities that might work to turn the curve, that's totally fine, because this next process is really just going to be looking at those activities and transforming them into measures. So like I said before, when we think about the measurement piece and turning strategies into measures, differentiating between process level and system level is going to be really helpful because you're going to be noticing a different tone, if you will, of the two different types of measures. So here we're thinking about the process level activities that we had generated in the past step. So the first activity for our proposed case study was conduct parental interviews for SID/SUI cases to inform safe sleep activities. So a way that we might go about measuring that activity to see if we're really doing what we said we were going to be doing is by counting the number of parental interviews conducted for SID/SUI cases, stratified by race, ethnicity of cases, and geographic location. So then our next activity was provide training to hospital staff and providers on the complete infant safe sleep environment curriculum. So we do that activity, and the way that we're tracking and measuring to make sure we're hitting the mark is to measure the percentage of hospital staff and providers who report confidence and ability to implement this curriculum. Our third activity was to provide safe sleep counseling to WIC and MCV clients, and the way that we were assessing that was by measuring the number of WIC and MCV clients who report an enhanced understanding of safe sleep practices following a structured counseling session. So, and these examples are on page 10 of your workbook, and I want you to keep that in mind when we go to this next slide and look at the system level activities and what those measures look like and how they might feel a little different. So our system level activities included partnering with hospital systems to develop safe sleep policies. And a way that we might measure that is the percentage of hospital systems that partnered with Title V safe sleep initiatives. Our next activity was to provide guidance and oversight around SID/SUI's coding to state medical examiner office. And the way that we were measuring that was to look at the percentage of staff in the state medical examiner's office who report an increased understanding in SID/SUI's coding. And then our last activity was to look at an increase of access and visibility to hospitals that report having a safe sleep policy. And the way that we thought about measuring that was the number of hospitals that report having a safe sleep policy. So if you're thinking through how these measures differ from process level to system level, you might see that the process level are really getting into the weeds of looking at an increased understanding, an increased ability to implement, fidelity, things like that kind of get at that deeper level, whereas the systems level might be at that higher level of just counting counts or looking at percentages. And that kind of goes back to our conversation we have earlier where we think about the activities that are really in the wheelhouse of Title V, and then the activities that might be more at the systems level where Title V is still a key player, but they're kind of acting as a broker or a convener of other partners that are also working to get this work done. So when you think about those two different types of activities, you can see their differentiation between, are we just counting counts, are we just looking at percentages, or are we really looking at what impact our activities are having? Are we increasing knowledge? Are we increasing skill? Are we looking at fidelity in implementing certain policies and so forth? So we're going to spend some time working on the process of developing measures, but then we're also going to be thinking through how these measures fit into the RBA framework and how you could categorize these different measures. And the reason why that's important is just so that you have an understanding of where your different measures are touching and what kind of spectrum they have across your work. So we're going to give you some time now to go through the activities that you talked about in the last step, so whether those are things that you generated or just activities that you're working on in your agency in the day-to-day, and work on that process of transforming them into measures. So really looking at number, percentage, but then also thinking about, do we have the data or the capacity available to really go deeper and look at, are we increasing skill, are we increasing knowledge, are we getting at those deeper level measures? So again, just keep in mind when you're working on this, these measures really follow the work. It's the process level, it's the work level measures that you're going to be developing now. So a few minutes to take a look at your strategies, transform them into measures, and then we're going to talk a little bit more about the strength of measurement as well. In your workbook on page 10 is where you'll be filling out this measurement piece. But then also on page 9 in your workbook, there's some really great tips and tricks about developing measures. So you could go ahead and take a look at that with your group before you dive into developing these measures. Are there any questions? And you guys have 11 minutes to work through this process.
All right. Thanks, everybody. We are amazingly, wonderfully on time. This feels so good. But we're not done yet. I think I'm going to back up a little bit. Some of the harder work is coming up. So, we've been really brainstorming a lot of ideas, and this feels good. And I know some of you have been working on already, how do we strengthen current ESMs? Well, in this next part, so RBA is really good. Let me just get rid of that. Okay. RBA is really good in helping us classify measurements. Let's just turn it off completely. Oh, so much better. Thank you, Deb. Yay. All right. So if any of you have seen our ESM reviews that we sent out to the states, if you've looked at the national review, or if you've been to our partnership meeting, you'll be familiar with these 4 quadrants. And these are one way of looking at how we measure ESMs. So you've come up with some really good ESMs, but there are ways to then plot them out in how we measure them. So let's just take another deep breath and talk about how to measure ESMs in this 4-quadrant approach. This is not the only way, and it's not set in stone. It's just a way, again, thinking about how to make your ESMs a little more measurable. So basically, in this 4-quadrant approach, we are looking at measuring the quantity or the quality of the effort and the quantity or the quality of the effect. So we have our 4 zones. So zone 1, we're talking about the quantity of the effect. And this is how much service did we do? How many meetings did we go to? How many partners did we get to? How many providers were trained? Now we're measuring quality. This is how well did we deliver the service. This also includes some customer satisfaction. There are percentages here. So this is really a percent of the effort. What percent of hospitals in our system are baby friendly? What percent of providers have been trained? So this is sort of the distinction between the first 2, and this is where you're going to find a lot of these. In quadrant 1, we have the most control over this. Quadrant 2, we have a little less control. 3, even a little less, and 4, it gets a little scary because we have the least amount of control. But in quadrants 3 and 4, so we're in quadrant 1, we measured what did we do. Quadrant 2 is how well did we do it. But we want to push, and sometimes, and I will tell you, this is a big secret. Sometimes it's okay to just measure numbers and percentages, especially if you're at an initial stage. Our programs have a development. It might be that in the first year of a program, all you can do is count the number of providers that you have, or partners that you have at a table. And that's great, but is that ESM? You have to ask yourself, is that really an indicator of how you might be moving the NPM? Probably, partnership is important, but there are better ways to measure the numbers. But you might be fine here to start with. You might also then, if I'm going off target a little bit, but let's talk with this number of partners. Let's tease this out a little bit. You might then look at, first year you can only measure the number of partners you have at the table, but the next year you might look at the number of partners you have from outside your organization or outside of public health. Then you might also look at tools, and this is where the Evidence Center is really good. If you're saying, I'm not sure exactly, I have the CSM, we've been using it for a while, we're not seeing the change we wanted, how can we make it stronger? say, well, have you ever considered, in the partner example, have you ever used a tool called the Wilder Collaboration Inventory? And you'll say, what? No, I've never heard of that. And we'll say, oh, it's really great. It's a 20 tool that really helps you more than just measure numbers. It helps you gauge the collaboration among your, if you really want to measure partnership, and that's important, this is a tool. There are all kinds of tools to help you move down the system. So now we're getting into quadrants 3 and 4. Now that I took our little detour, back to explaining. This is anyone really better off? And again, we might not be looking at women, infants, children, youth, and families. Our customers, this is what we're looking at. Our customers might be the providers who need training. Well, have the providers, we might measure in quadrant 1 the number of providers we've trained. Then we might measure the percent, and did they like the training? In quadrants 3 and 4, have they learned something? Have they increased their knowledge? And in quadrant 4, which is getting really, this is almost population level, except for scale. Have we improved their knowledge significantly better than where they were before? So it's imprecise, but it starts getting you thinking. If you can start mapping your work on these, you can see where you fit. And you probably want a mix of quadrants 1 through 4, depending on the life cycle of your strategy, of your program. And that's great. And you might be really successful. You might say, oh my gosh, we have been measuring, this is great. Now let's measure something else. And you might start back at 1 or 2 and then move up. So again, it's just one of our ways to get us thinking about how are the programs and the strategies that we develop, do they affect the causal roots? Do they use our partners? Do they use our resources? And will they hopefully have an effect on the NPM? Oh, yes, another example.
So here's an example I just heard when I was walking around. The breastfeeding group there, back in the corner, was having a really great discussion about worksite breastfeeding interventions that they've been piloting in a couple of different states, and a couple of states said that one state's giving out little mini grants for work sites, small work sites like gas stations, for their staff to be able to pump, for example, or breastfeed a baby at work. And so I asked, how is this being measured? And both groups said in the initial years, they're really just literally counting the number of grants they give out. But the long-term plan, right? So that's number 1. You're counting essentially the number of people that you've trained or the number of grants you've given. Longer term, their plans are to go back and measure utilization. How many of these grants were used? Are the breastfeeding facilities that they built and the gas stations being used? So they're going to go deeper in subsequent years, and that's a very normal trajectory as you're developing ESMs. If it's a new program, it's perfectly okay to write an ESM in quadrant 1 as long as you know that the ESM should be different 3 years from now and 5 years from now. That as the years go by, you're working your way up. Not that you're ever going to count the number of trainings you do or ever stop counting the number of trainings you do, but you are going to add additional layers onto your measurement as time goes by.
Oh, that is very helpful. Thank you, Amy. And the idea is how we keep saying you're brainstorming a lot of ideas here, and a lot of the programs that you do, a lot of the activities, you're going to be doing them no matter what, and you're going to be counting them. You don't necessarily always have to report on 6 different ESMs for each project. So here again, it is helpful to use the one that seems like it is the most indicative of that work that can lead to the greatest change. So I wanted to take on this side. It's a little small, so I'm going to read this to you. And it isn't in your workbook. I will also say that copies of the workbook we have print copies up here if you want to take some back with you, but we also will have it on our website, so mchevidence.org. If you find that useful. So another way of looking at measurement here in the category of what did we do, you can look at the number of customers served and the number of activities. The how well did we do it, this could be common measures like a workload ratio, the percent of staff retained, customer satisfaction that measures did we treat you well, did you get something out of this? Is anyone better off in that third category? These are numbers. So the number of providers who've increased their skills or knowledge, the numbers who've changed their attitude or opinion, the numbers who've changed their behavior, and the numbers who've changed their circumstance. Then we get to the fourth. This is looking at these categories compared to a baseline, the percent of providers who've changed their skills, the percent of families who've changed their attitudes and opinions. And again, here you might say, ooh, this sounds an awful lot like our NPM, because we're talking about the number of children placed to sleep in a safe sleep environment with all the environmental factors being met. Here it's a question of scale. That quadrant 4, we're looking at a smaller scale. Remember, again, we're just looking at what Title V is funding or what your partners who you're funding are doing. So we're not looking at the whole state. We're not looking at the whole country at this point. So it's kind of a way just to put it into perspective. In the examples that Al earlier, we have back to safe sleep. If we sort of map them, these quadrants, we found that we have mixed things. Is this precise? No. Is it important? Yes and no. I mean, it's good to know that our numbers are here. We have a percent up here. Then we have, the number of clients, enhanced understanding. It makes sense. There can be some shifting. Again, it's just this kind of activity. Once you've generated all these ideas for programs and you map it across here, you can kind of say, these are the ones there's some easy ones that we can do and check off, and there's some ones that are a little scary for us, and we have to push the measurement, but we should do that because we think that they have a great chance of making change. So in our typical fashion of asking you all to do the work, so we want to take a few minutes, again, and you have the 4 categories up here, they're in your workbook. If you developed any of your measures that from the last little time, if you want to take a look at those and among your group, see if you can come to consensus. Do they actually fit in these categories? Do you have questions? If you say, oh shoot, all of ours are in category 1, are there ways that you can reword them or rethink about the data to get them into a higher category? So again, this is tough work, so we're going to give you a few minutes to do this. And we'll also be floating because I'm sure there'll be questions. So before we break out, are there any questions on the content? All right. I think this is our breakout activity. So we're almost there. So one more time, take a go round, and we'll touch base in 5 minutes. All right. All right, everyone. We're going to sort of pull together now. And I hope what you're realizing, I mean, this is tough work, and it's not precise, like I said, but this gives you a sense of, okay, where can we go with these? I also want to say, give everyone just a second to pull together. All right. So I also want to say that don't worry, when you go back home to your teammates, you might say, oh shoot, we learned all of this stuff and we are way down in category 1 and 2. All right. If you're way down in category 1 and 2, don't jump out a window. We're not judging you. Well, we might be judging you, but not for those reasons. No. But this gives you a sense, if we look overall across the field where we are, we're all in the same boat. But it gives us the freedom to explore and to make this better. So nationally, if we look, we are probably pretty much, the red is category 1, blue is category 1, red is category 2. 3 and 4 are really small, but this is aspirational. This is us getting there, and we can actually do that. You'll see in category 1, almost all of them, 76% are counts, 24% are still yes-no activities. Here I will challenge you. we can do better than this. We can make these stronger. Maybe not for every measure, and you might be counting this anyway. You might retire that ESM. You might be using one that's a little stronger. Category 2, about 62% are focused on clients, 38% are what we call systems building. This is not bad. When we get to category 3 and 4, it's about 50-50. 50% of them are measuring skills, 50% are showing systems change. It would be great, if you can, push yourself a little bit here, and that's why we're here. We love to feel loved, and we're here to talk to you. We're here to talk, to give you examples. You also see too, because we love the pyramid, we're always trying to move down the pyramid. This is very safe sleep specific. So you'll actually see, if we look, there are currently 56 ESMs across the states and jurisdictions that are doing safe sleep. Only one of them is in direct service. That's good. We are moving down the pyramid. Most of them are in enabling services, which is okay. We're not focused on services, but we still don't have any that are really dealing with the public health services and systems. This is where Title V is strong, and this is where we can really be measuring that work. So that's sort of our call to action. But I'm going to pass this over to Amy, who's going to sort of summarize a lot of what we've been talking about.
All right, you've reached the end of our journey. Where's my road? We're at the end of the road. Thanks for joining us today. In summary, I just want to go back to 9 a.m. and the beginning of what we talked about and remind us all that RBA is not the only way to think about the work. It's one way that can help us. I think one of its greatest strengths for Title V is giving us the ability to visually see the outcome measures linked to the performance measures, linked to our activities, and linked to what we are actually measuring when we carry out our activities. I feel like that's the biggest potential leverage point for RBA overall. The second leverage point is this 4-quadrant system, which at the top, as John just described, we're measuring how much we're doing, and at the bottom we're measuring, did it matter? What we did it matter? That also comes directly from RBA. So in my mind, those are the two probably biggest benefits of this framework for our work in Title V. I want to reiterate what RBA does not do is provide you any sort of evidence about what works. That's why the Evidence Center is here. That's why you have your practice experience and all sorts of other resources. But in case you are looking to get the book, it's not going to tell you what the evidence is for what you're doing. It's also not going to tell you how to do your activities in an implementation-informed way. It's really just going to tell you how to think through the framework. You're the experts in finding the evidence and doing the activities, but it's not going to tell you that. And the other thing we mentioned earlier, the RBA practitioners across the country are really working on thinking about how to apply an equity lens to the RBA framework, but they haven't gotten very far yet. So if you plan to use this, please make sure you're actively thinking about the equity angle and infusing that into your work as you go. Here's our contact information. For those of you who are interested in continuing the conversation, we will have an exhibit table here at the conference. You're welcome to come talk to us there and get all John's free stuff so he doesn't have to take it home in his suitcase. And then Dorothy, do you want to do the evaluation piece? You want me to do it? Okay. So we really want feedback on how we did today. So go ahead. I think there's another star on the back side of the initial star. Please circle. We're just interested in seeing whether or not your star rating went up in any way today. And then there are green evaluation forms under your table tents. Please, if you don't mind taking the time to fill out those green evaluation forms, that would really help us improve our services in the future. And please give yourselves a round of applause for all your hard work today. Thank you.